Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. I am not getting any younger, and regrettably, dear listeners, neither are you. But the good news is that with age comes wisdom, and wise physicians know the importance of streamlining medications for patients with complex diseases. The manuscript we will discuss today is Optimizing Medication Use in Older Adults with Rheumatic Musculoskeletal Diseases, Deprescribing as an Approach When Less May Be More. It was recently published in ACR Open Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I am pleased to be joined by two of the authors of this paper. Dr. Jiha Lee is an assistant professor at the University of Michigan. Dr. Lee is a member of the Junior Investigative Intensive Program of the US Deprescribing Research Network, which the National Institute of Aging funds. She is also the principal investigator of an RO3 investigating treatment patterns in older adults with late-onset rheumatoid arthritis. And Dr. Una Macris, the senior author of this manuscript, is also well known to many of our listeners. She is an associate professor of medicine at the University of Texas Southwestern and the Dallas Veterans Affairs Medical Center. Dr. Macris's clinical and research career bridges geriatrics and rheumatology, and she is the recipient of a VA Health Services Research and Development Award. Everyone who knows Dr. Macris knows that she is exceptionally skilled at uniting diverse teams on collaborative, multidisciplinary projects. Welcome to the show, Jiha and Una.
Thank you for the kind introduction. It's an absolute pleasure and privilege to join you together with Dr. Una Macris to talk about a topic that is really near and dear to my heart.
Yes, thanks so much for inviting us both.
And Jiha, I am going to start with you, and I wondered whether you could first tell our listeners a little bit about the US Deprescribing Research Network and how you got involved with that group.
Yes, so I was first introduced to deprescribing as a way to optimize medication use and related outcomes in older adults, particularly during my fellowship at Yale University. I was really intrigued by this concept, and over the next few years kept abreast of the literature and sought opportunities to do more exploration in this field. And during this search in 2019, I discovered the then newly formed US Deprescribing Research Network, which stemmed from a group of researchers and the National Institute on Aging, recognizing the need to create a community of people united by a shared interest in improving research on deprescribing for older adults. And so in 2022, I was selected into the Junior Investigator Intensive Program and have been participating in network activities for learning and collaboration around deprescribing research.
And Una, you have been working at the intersection of geriatrics and rheumatology for years. I know it's your passion, but tell us what drove that interest and how it's evolved over the course of your career.
Absolutely. So my love for geriatrics probably started early on as a child. I used to spend hours on porches speaking with my grandparents in both Serbia and Croatia every summer. So I really developed a love for hearing other people's stories. I have great respect for older adults and for what we can learn from their lives and also what younger generations can do to connect with older adults. Then later on during my residency at University of Washington in Seattle, I rotated through the VA Transitional Care Unit, and my attending, by pure luck, was the incredible Dr. Bill Hazard, who happens to be the grandfather in many ways of gerontology. It's actually his name on the famous Hazard's Geriatrics textbook. So I was in the process of deciding on fellowship applications at the time, and he spent a lot of time inspiring me to pursue my passion. So I already knew that I loved immunology and rheumatology, and he heard my interest in geriatrics and confirmed that I could do both. And I think that all of us understand that there will never be enough geriatricians out there to take care of all of our aging patients. So as a result, It's critical that specialists, both medical and surgical specialists, learn the core principles of aging and integrate that into our practice in order to optimize outcomes for this unique patient population. I will say it's possible to do a double board in geriatrics and rheumatology. I chose to focus my research on geriatrics and completed a T32 through the Yale Geriatrics program, focused on clinical epidemiology and aging research. And so I think it's possible to do both clinical geriatrics and rheumatology or focus on research within aging.
And actually, so I'm going to take advantage of some of your background then. I wondered if you could actually give us a little bit of a quick tutorial on some of the geriatric concepts that you mention in the manuscript. In particular, ones that I think will be important for us as rheumatologists to know. Can you tell us what are the geriatric 4Ms and 5Ms?
Absolutely. So this is really one approach to systematically remember to address geriatrics principles in our older patients with rheumatic diseases. As proposed by the Institute of Healthcare Improvement, the 4Ms are a set of 4 evidence-based elements of high-quality care in older adults consisting of the mind. We usually think about mentation, depression, delirium, dementia. The second M is mobility. Here we ask about physical activity, function, falls, mobility devices. The third M is medications, which we will speak more about today. And this really includes acknowledging polypharmacy, the importance of optimizing medication management, prescribing cascades, and monitoring for potential adverse events. And then the fourth M is what matters most, perhaps the most important of the M's, where we get to understand the goals and priorities of our patients over time. Then the fifth M, which stands for multi-complexity, was added later. Multi-complexity describes the whole person living with multiple chronic conditions, advanced illness, and or complicated biopsychosocial needs. And taken together, the consolidated framework known as the geriatric 5Ms helps to ensure that older adults receive the best care possible, are not harmed by healthcare, and are satisfied with the care they received. I would say that the key for the 5Ms is understanding that our older adults with rheumatic diseases are unique and will often require a different approach than our younger patients. I would also ask that our rheumatology community think carefully about learning more about these core aging principles, how you might integrate these concepts in your clinical care and practice. And ultimately, we need to understand and evaluate how this age-appropriate approach impacts outcomes for older adults with rheumatic diseases.
So I want to touch on this concept of prescribing cascades. And Gia, I'm going to ask this question of you. I'll confess to both of you that I think I've created many prescribing cascades in my career, and I suspect that will be true for some of our listeners, but I never knew this had a name. Can you fill us in? What is a prescribing cascade?
Yeah, absolutely. I think, like you, I have been and still guilty of contributing to a prescribing cascade. And this is not a vocabulary or term that we as rheumatologists are familiar with. But in fact, the term was actually coined back in 1995 by Rokon and Gurwitz. And it refers to the phenomenon when a new medication is prescribed to treat the adverse side effects of a previously prescribed medication that are misdiagnosed as a new clinical condition. And so subsequently, this leads to inappropriate, unnecessary, or potentially harmful additional drug use. So for example, a patient with arthritis may use NSAIDs to treat their joint pain, but then they notice that their blood pressure is elevated. They go to the doctor's office and are diagnosed with hypertension and get started on a calcium channel blocker. A few months down the road, they notice that their legs are swelling and go back to the doctors. And this time, to treat the leg swelling, they're put on a diuretic, which then down the road leads to the patient experiencing gout attacks and having to take on even more medication. And so the prescribing cascade, understanding this concept and recognizing that how we may be contributing this helps us recognize that we need to be critical about the assessment of symptoms and presentations so that we address the problem, which may at times involve removing medications rather than adding on medications.
Yeah, and actually, I guess that brings me to my next question, that you present some data in the manuscript about the scope of this problem in patients with rheumatic diseases. Can you share that with us? How common is this problem, and how much does it impact the patients that rheumatologists care for?
Absolutely. So the prescribing cascade is one way in which we contribute to polypharmacy, and polypharmacy defined as the concurrent use of 5 or more medications at a given time. We see this in 1 in 2 older adults with rheumatoid arthritis and about 1 or 3 adults with lupus diagnosis. In the general population, when they looked at the impact of or the prevalence of prescribing cascade in terms of antihypertensive medication use, what they found is that 7 to 10% of older adults were given another diuretic 1 year after starting a different blood pressure medication. Now, specific for rheumatology, we have yet to really define or identify rheum-specific prescribing cascades or what are more common prescribing cascades. So it's hard to quantify, but extrapolating from the general population and knowing that our patients actually have more comorbidities, it would be an underestimation to say that our patients are not impacted by prescribing cascades.
Oh, I absolutely agree. I feel like, we've all been there prescribing kind of induction doses of steroids when we add then a proton pump inhibitor or some kind of gastroprotection, some kind of bone health protection. I feel like we do this all the time. So next, tell us a little bit about this kind of reverse concept, this concept of deprescribing, because I want to be quite clear here. You are not recommending de-escalation of care. Can you explain to us what deprescribing is?
Yes, absolutely. We as rheumatologists or any physician, we are not trying to withdraw care nor deliver suboptimal care or de-escalate care. But what deprescribing by definition refers to, it's the thoughtful and systematic process of identifying problematic medications and either reducing the dose or stopping these medications in conjunction and shared decision making with the patient in a manner that is safe and effective. And the goal is to really help the older adult maximize their wellness and goals of care. So we talked about, it's not about withdrawal, but it's more of a way of addressing polypharmacy, not just by reducing the number of medications, but identifying and prioritizing medications that are inappropriate, unnecessary, or harmful, and trying to reduce the use of those medications. And this approach really aligns with the geriatric 4M framework or the 5M framework that Dr. Una Makris talked about earlier. And this concept has been adopted and garnered interest from other specialties, including cardiology, GI, and oncology. And I think we actually see this concept mirrored in our updated ACR and EULAR guidelines, where for RA, they say to consider tapering gradually or withdrawing DMARDs for those who have, and this is the important part, have reached remission or have low disease activity for at least 6 months. So we are recognizing that we want to maintain the benefits of treatment, but at the same time be cognizant and continuously and frequently assess the safety, effectiveness of the medications that we prescribe and try to ensure our patients are on the lowest effective dose. And that, in essence, is what deprescribing is about.
Yeah, that's really helpful. And I kind of love this discussion because it makes me think a lot about the art of medicine and perhaps kind of drawing some parallels from the art world. We often think of artists as people who create something by adding something. They're painting on paper or drawing or creating a piece of music. But we should also remember that there are some people like sculptors and tailors and dressmakers who create art by choosing to remove things from the materials they work with. So, Una, I'm going to loop you back in now because you have been practicing at the intersection of geriatrics and rheumatology for years, and you are very skilled at sculpting and tailoring management plans to the needs of your patients. There are some guidelines that the American Geriatric Society has developed for medications, particularly to avoid in older adults. I think they're known as the Beers criteria. Could you tell us about the Beers criteria, who developed them, and who is maintaining and updating them?
Certainly, the Beers criteria or the Beers list was originally developed by Dr. Beer back in 1991. These guidelines are now published by the American Geriatric Society and updated every 3 years with a multidisciplinary interprofessional panel of geriatrics experts that reviews the literature. So the drugs listed on the Beers list are categorized according to risk for negative outcomes. It provides guidance on potentially inappropriate medications that should be avoided under most circumstances or depending on certain drug disease and drug-drug interactions. Beers criteria are intended for healthcare professionals to improve the safety of prescribing medications for adults over the age of 65 in all settings except for the palliative care setting. It really emphasizes deprescribing medications that are unnecessary, and that in turn helps to reduce the problems of polypharmacy drug interactions and adverse drug reactions. The criteria are used in clinical care to monitor and improve quality of care. They can also be used in training, research, and healthcare policy. I want to emphasize that Beer's criteria are intended to serve as a guide for clinicians, but not to substitute our professional judgment or shared decision making with our patients. I want to say the most recent updates for Beer's criteria are in 2022, and Dr. Lee has an important role as she is currently having discussions with American Geriatric Society how to evaluate Beer's criteria through the lens of a rheumatologist. So I really think this will help our field tremendously.
Ooh, I'm sensing a future manuscript coming on, Jiha. So I'm going to draw you back to this current manuscript, though, because in this manuscript, you do give a pragmatic approach for rheumatologists to use in practice. And in the manuscript, you do have this beautiful flowchart graphic. I'm wondering, can you describe it for our listeners?
Yes, absolutely. So I wanted to create a flow chart that would help our rheumatologists conceptualize and identify opportunities to optimize medication use in older adults. So the flow chart really starts with first recognizing and screening for polypharmacy, and then ensuring that we carefully review all medications for their indications. As rheumatologists, of course, our primary responsibility and our training lies in the safe and effective use of DMARDs as well as steroids. So in the flow chart, the foremost is ensuring that we prescribe DMARDs to reach our goal of disease remission and or low disease activity. But then for those who have actually achieved that goal, to go back then assess, are they on the lowest dose possible? Because studies more and more are showing you don't need the same amount of immunosuppression to maintain disease control, but the medications that we use are high risk. And older adults, because of their comorbidities, are more vulnerable to these negative side effects of medications. So the continuous loop process that is depicted in the flowchart is to really emphasize the need to continuously assess the benefit harms of medications and to try and reduce the dose whenever possible. And it's important to know that this is often going to be an ongoing and a dynamic trial error based process. And we will be going back depending on how they do to go up, down, up, down. So it's across the lifespan of their care. In this flowchart, though, the other thing that I wanted to mention, as Dr. Macris mentioned, is that there are, based on Beer's criteria, some potentially inappropriate medications that are commonly used in patients with RA to either treat their comorbidities or treat some of the symptoms. And these medications include antidepressants, benzodiazepines, gabapentin, opioids, and skeletal muscle relaxants. And they have drug disease interactions that, for example, increase the risk of falls in older adults. So even though we may not have initiated our patients on these medications or may not be very familiar with how to manage these medications, I think we still bear the responsibility to recognize what is harmful, in particular for our rheumatic patients, and bring that to the attention to our other care network providers, such as clinical pharmacists, geriatricians, so that we can all collaboratively ensure that our patients are optimized on their medication management.
Yeah, and I guess this is somewhere where the electronic health records can be both a help and a hindrance, right? Because, it's super easy to just click renew on the electronic prescribing. Whereas when we had to sort of hand out each prescription, you really thought about, does this need to be renewed? Do I maintain the same dose? Should I change the dose? So I do think sometimes as we've advanced in technology, we really have to be very thoughtful about how we approach maintenance of disease for our patients. And so, Jiha, as we kind of wrap up this discussion, I'm interested to know where you see this field going in the future. You mentioned one thing in the study that I think is worth drawing out, that older adults and patients with multiple comorbidities are poorly represented in many of our randomized clinical trials. And I guess there aren't very many studies specifically assessing deprescribing in rheumatology patients, even just in our kind of routinely collected clinical data or through things like the RISE registry. I wondered whether you could speak to that and speculate a little bit on where you think the field might be going.
Yes, certainly. I think there's much more to be learned and achieved in this field, and that's reflected in the fact that both ACR and EULAR have outlined when, which, and how should DMARDs to be tapered discontinued as a key clinical question that requires further research. And I can foresee where the gaps in knowledge are, in that we need more evidence base to develop deprescribing protocols, to evaluate their effectiveness comparatively, to see what is cost effective. We have yet to understand the role and utility of biomarkers or advanced radiographic studies to identify high value targets for deprescribing. Some of the randomized controlled trials have shown 30 to 50% are able to deprescribe, maintain disease remission. And in clinical practice, we kind of talk about the rules of thirds. So for older adults in particular, to be able to identify who will benefit most from and be able to deprescribe, I think, is an important question. And also, the one thing with deprescribing is to understand that just as how we monitor for side effects of medication use, it's important to recognize and monitor for medication withdrawal side effects, which can often be different from medication-related side effects. So we really need deprescribing specific outcome measures as well as quality measure development to ensure that once we have more evidence base for deprescribing approaches, that we're able to assess ongoing effectiveness and make adjustments. And in terms of doing more study in the older adult, you're right. For ethical reasons, there's very little representation in clinical trials. So oftentimes Medicare claims data are helpful in doing observational studies, which is what I'm doing. But the US Deprescribing Research Network also recognizes that this is an area that needs addressing. So they actually have groups that are focused on certain aspects, and one such is a data harmonization working groups. So they're actually developing and testing methods to use the electronic health record to identify inclusion-exclusion criterias, characterize medication use, measure important outcomes relevant to deprescribing, so that pragmatic deprescribing trials can be conducted with more inclusion of older adults. And I think we can leverage and definitely collaborate with USDEN and other specialty researchers in this space to then develop more rheumatology-focused research agendas and approaches.
Oh, that would be fabulous. So really kind of some real world approaches to this problem that I think would be very helpful. I'm going to change direction now and take you, both of you, down a little bit of a discussion about mentorship. And Una, I want to start with you. You have been an enormous supporter and mentor of women in rheumatology, but I wanted to ask you a searching question. How do you decide who you will mentor? What do you look for in a mentee? And how do you nurture those relationships?
I love the topic of mentorship. And really, I've been so lucky to be able to mentor wonderful colleagues. I think that mentoring is truly one of the most gratifying parts of our career. I would say that I generally mentor others in one of 4 areas. So if someone approaches me based on my content expertise, for example, older adults with musculoskeletal pain or behavioral interventions. This aligns well with what I do. Similarly, as a health services and outcomes researcher, if someone approaches me about mentoring on a methodology that I have expertise in, this also aligns well and is a good fit for me. So, for example, I've absolutely loved working with our pediatric rheumatology colleagues on transition of care from pediatric to adult clinics for childhood lupus. Clearly, this has little to do with my older adults with musculoskeletal pain. However, in this situation, I can provide expertise and guidance about qualitative methods and survey design. So, a third category of mentees that I enjoy working with includes anyone interested in bridging their career as a medical or surgical specialist in aging. I live at this intersection of rheumatology and geriatrics and really enjoy helping colleagues along in this niche. There's really so much we can learn from each other, so it goes both ways. And then the fourth type of mentoring I provide is more along the lines of career mentorship, how to navigate difficult decisions along the way, both professionally and personally. I find this tremendously gratifying because we might be able to influence or inspire someone along their path. And similarly, I think that peer mentoring is very important. I've noticed the importance of peer to peer interactions with regard to engagement, productivity, and professional fulfillment. I'll speak briefly as a mentee because I think we're all lifelong mentees in many ways. It's important to know what you're looking for during each of your mentoring meetings and to come prepared, often with an agenda, and to use your mentor's time wisely. I really like to have a cadence of meetings with my mentees, and it keeps us on track.
Yeah, I think that's really great advice. Jiha, you're a little earlier in your career, but you have obviously been extremely successful and already achieved RO3 funding. So I'm sure you've had outstanding mentorship and guidance in your early career. What tips can you share for other early career investigators on how to find a mentor? And more importantly, I guess, how to nurture those relationships from the mentee standpoint?
Yes, absolutely. I mean, mentorship is so important, and I've been incredibly fortunate to have an amazing group of mentors. And just like they say, it takes a village to raise a child, I think it takes a group and a community of mentors. And I don't think that concept came to me until a little later. For some reason, I think early on I had in my head that I would have the one mentor who's going to see me through and help me succeed. So I think once I realized, as Una pointed out, she mentors in different capacities, that as a mentee, I need to recognize what my needs are. And those can be career driven, methodologically driven, or even just, life reasons to then for each meet mentors and establish those individual relationships. And sometimes the mentors come together to have more of a group experience. And so that really enriched my mentorship. And in addition to that, looking outside was key for me, particularly because my research interest was in the older aging population. Branching out into the geriatric space allowed me to identify people with more specific niches and expertise in alignment and kind of emulate the path that they've done. And similarly, because I'm trying to bridge both geriatrics and rheumatology, I found different communities, for example, the ClinStar community, where it's specialties from all different areas, cardiology, oncology, also doing aging research. So we get to kind of share in the experience of bridging two different fields. So I think in that regard, I would advise any other to look outside, just even knowing what opportunities are and seeing what other similars are going through in the path, I think is very helpful. And in terms of the relationship, as Una said, I think it's really befalls on the mentee to be steward of that relationship. So as Una said, I like to have regularly scheduled meetings with my mentors because that keeps me accountable, but also keeps the relationship strong, and that making sure I have set agendas, deliverables, and make sure I communicate that very clearly with my mentors and recognize that because they have competing priorities, to make sure that we establish a timeline where successful and also productivity can be ensured.
Yeah, really good advice. I am actually going to return a little bit to our artist mentor from earlier because I kind of think of careers as a little bit like a mosaic. And there are times when, like the prescribing cascade, it's right to add more tiles to the wall. And there are times when, just as with deprescribing, you have to make kind of prudent decisions about what to take away or where to redirect your efforts. So, Jiha, as an early career rheumatologist, you're in this phase of adding more tiles. And I think early on, many of us will say yes to every opportunity that comes our way. What tips do you have for early career rheumatologists on deciding what opportunities to pursue? And particularly, do you have any advice for people who are trying to branch out into a new area, as you did with this deep prescribing and geriatrics, and really are looking for a way to connect with some of the established investigators in the field?
Yes, absolutely. And I must say, I love your metaphor of mosaics. And I kind of chuckle a little bit at this question because I know for sure I'm guilty of saying yes way too many times and overcommitting. Because when you're junior, you're just so happy to be invited to the table. You don't look for what's on the menu or what it means. But over the years, what I've learned is it's helpful to have some principles. So one, I go to my mentors and I ask them if I'm not sure, they've lived through this before, and I ask them, is this something that you think will be helpful for me? And if I need to say no, I ask them, how can I tactfully say no? Because I don't necessarily want to forego that relationship or potential in the future. And I think the other is I ask, is this opportunity something that's aligned with my mission and long term goals? For me, it's about optimizing medication use in older adults. So, will it promote that field or will it allow me to make more connections between geriatrics and rheumatology? And I think, thirdly, it's about the connections with the people. So, if it's people that I want to potentially collaborate with the future or somebody that I can learn from, and this is one opportunity that aligns, then I will say yes. So I think having some boundaries or guiding principles can help. And as you said with the mosaic, sometimes though, I will say yes to other stuff. And it's interesting. It was only recently where I realized all these little pieces or tiles came together and I was able to tell a collective story or realize I was able to utilize all the skill sets that I've had. So I think at the beginning, yes, you can say yes too much, but lean on others, listen to your gut, and have a long-term outlook on it. And you can be as smart about it.
Yeah, I think that's really good advice. I'm sure you're not the only early career investigator who says yes to many things. And I agree with you. I think as you're kind of putting the tiles on the wall, you don't necessarily know exactly what the finished picture is going to look like. So, Una, you're now mid-career, and it's a different issue once you kind of get a little bit more senior, because there you only have so many hours in the day. How do you decide where you're going to spend your time and effort? And do you have any frameworks you use to decide what the mosaic of your life will look like?
So I think my general principle that guides me is I want to contribute to activities that I feel will make a difference, either for outcomes for my patients who tend to be older adults or for colleagues with respect to mentoring efforts. I'm a clinical investigator, so my approach in general is to have 1 to 3 threads that are truly my own and that I am driving forward with funded efforts. And the other projects tend to be collaborative. When choosing to say yes or no or prioritizing opportunities, I really love the metaphor provided by Stephen Covey. You may be familiar with it, the rocks of life. This is where we acknowledge that we have a finite glass container and first place the large rocks. These are our big priorities in life, both personal and professional. And then we place the pebbles and sand all around the larger rocks. And I can't say that I always do this well, but it's a work in progress. And sometimes I need to remove some of those rocks or tiles, as we discussed earlier, that weigh too much.
Yeah. And I think that's fine, right? And we actually should be more comfortable with doing that when the time is right. So I guess I wanted to ask both of you now. We've talked about how you mentor others. I wondered whether you would be willing to share about some of your formative mentors who've shaped you as a rheumatologist. And Jiha, I'm going to ask you first. Tell us about some of the people who've helped you along the way.
Yeah, absolutely. I mean, like I said, I've had so many incredible mentors. I think because each and every one taught me different skills. But the one who taught me really to enjoy research as a process and the people was Dr. Liana Frankel during my fellowship. She would say simply, research is about figuring out the question you want to answer, finding a group of people you want to work with, and just having fun along the way. And I think for junior investigators, there's a certain degree of fear and barrier of getting into research because you feel like you have to achieve so much or you're not sure about your pathway. So I think the outlook that she gave for me really is what allowed me to stay grounded, have a long focus, but also just simply enjoy the process, not just the product. And for geriatrics, I'm grateful for mentors who, even when my research question doesn't align exactly with what they want to do, that they're very generous in terms of giving their time, their insight, and knowledge. So my mentor right now in geriatrics, Dr. Julie Bynum, she's entirely Alzheimer's research. However, she still takes interest genuinely in what I'm trying to do and understand, and gives me access to all of her resources that she has. So I think for me, those are the two in terms of the outlook that they provide, but also the willingness to help when it's outside of their scope of expertise.
Yeah, great advice. And Una, you have been a mentor to many, but I am certain you had several formative mentors in your early career. Are you willing to share any of those stories or the advice that helped you grow?
Absolutely. Dr. Lee and I are fortunate to both have Liana Frankel as our mentors. Liana Frankel was my rheumatology mentor while I was at Yale, and I will say that relationship is still strong today. I've also been grateful for mentoring from Dr. Thomas Gill in geriatrics at Yale. He really gave me my fundamental knowledge and passion for geriatrics. Kerry Reed is at Cornell, and he's an expert in pain in later life, and he's been one of my greatest sponsors. And then there's Eric Mortensen, who's actually a primary care physician, general internal medicine, who's been perhaps one of my greatest supporters over time. So one piece of advice that Liana Frankel shared with me was to find an exceptional research coordinator and nurture that relationship. As Jiha mentioned, she also encouraged us to surround ourselves with people who inspire us and, generally speaking, who enjoy the work they do. Because after all, our interactions at work constitute a huge portion of our lives. So I would give great credit to Liana Frankel for reminding us that what we do should be meaningful and also fun.
That's fabulous advice. And I think it's funny that you both picked Liana as your kind of mentor to discuss. And I hope she's listening to this podcast or that somebody tells her about it. So Jiha and Una, I really want to thank you for joining us to discuss your work. I've really enjoyed this conversation and your insights into the growing field of rheumatology and geriatrics and the intersection of the two.
Thank you. Thank you so much for having us. And it was an incredible joy to talk about optimizing medication use. And I hope this catalyzes more conversation among our rheumatology community.
Thanks so much.
So in this episode, we also give special thanks to geriatricians worldwide. They are some of the most skilled physicians, and I remain eternally thankful to the many geriatricians in my career who have taught me that not doing something, or even doing nothing, is sometimes the right thing to do. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRoom on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.